My name is Stephen Howell, and I'm a professor of mechanical engineering at UC Davis and orthopedic surgeon in Sacramento, California. And what I'd like to do is share with you an illustrative case of a patient that had severe loss of flexion in a knee that they had a mechanically aligned total knee arthroplasty on, but not in the knee that had a kinematically aligned total knee arthroplasty. And we'll look at whether it's from a coronal or axial malalignment issue. So let's begin by looking at the patient's limbs and seeing whether they're malaligned. And you can see the kinematic limb on the left and the mechanical limb on the right. And if you ask the patient which knee looks straight to him, he thinks they both look just fine. So from a perspective of the patient, he thinks both knees look exactly the same, or the alignment of the limb looks exactly the same when he's standing up. Now we have interoperative evidence that the kinematically knee restored the normal joint line, and this is his radiograph showing the wear on the medial side, and the MRI showing the loss of cartilage and the fluid-filled gap on the medial side, and the lateral side showing a normal joint space. And indeed, when we made the bone cuts, they were all pretty much equal with the exception of the medial side, which was 6. The distal medial side was 6. The posterior medial was, it looks to be 9 there, but we actually repositioned the component 2 millimeters to correct it. So it was 6, 7, 8 for distal lateral, 7.5 for posterior lateral. So we had a 2-degree correction in the coronal plane, and the posterior cuts were essentially the same. So the equal thickness of the distal and posterior resections, after we factor in the wear and the kerf of the blade and the adjustment that we made posterior medially, shape matches the femoral component to the prearthritic surface of the femur, which restores the normal distal and posterior joint lines on the kinematically aligned knee. Now, if we look at the femoral joint line, it's abnormal compared to the kinematically aligned knee in the mechanically aligned knee. And here you can see the normal joint line is in valgus with respect to the mechanical axis of the femur, and in the mechanically aligned knee it's actually switched to varus, and the difference between the two knees is 7 degrees more varus in the mechanically aligned knee, which actually raises the joint line and tilts it, and this means that all 3 kinematic axes in the mechanically aligned total knee arthroplasty are going to be malaligned, and you can expect some issue with the knee. Either it's going to be stiff, lose some flexion, or it's going to end up with some instability. Now, if we look at the tibial joint line, it too is abnormal from the normal joint line in the kinematically aligned knee. And here, some people might think that this cut looks too varus, but this was the normal joint line, as evidenced by the amount of bone that was removed from the proximal tibia being equal after you factor in the wear. And if we look at the cut on the mechanically aligned knee, it's actually an 8 degrees more valgus. So the tibial joint line is now abnormal. This means that the longitudinal axis in the mechanically aligned limb is not perpendicular to the two transverse axes in the femur, and this leads to kinematic malalignment. And again, you're going to have abnormal IR-ER, flexion extension of the patella and tibia, and expect either a loss of motion or the liners put in a little small so that you can get your motion back, but then you end up with instability. Now, of course, these problems are not all that simple. There could be axial malalignment of the components as well, but it turns out with axial CT that the rotation of the femoral component in both knees is the same. And you can then identify the epicondylar axis on the axial CT and then project it down to either the lugs on the component or the posterior joint line, and you can see that the axis or the angle formed by the femoral component axis and the epicondylar axis is the same in both knees, and therefore malrotation of the femoral component could not be a cause of loss of flexion in this particular patient. And the same question arises about the placement of the tibial component on the tibia. And again, it's the same in both knees. If we define the major diameter of the tibial component and then project it down at the ankle, you can see that there is really no malrotation of the tibia on the tibial component or tibial component on the tibia, and that therefore is not a cause of loss and flexion. So therefore the whole malalignment issue here is in the coronal plane, not in the axial plane. So let's look at the effect of this change in the joint line in the coronal plane of the distal joint line. Let's look first at the kinematically aligned total knee arthroplasty. There's the coronal projection of the femur and the axial projection, and you can see the transverse axis in the femur about which the tibia flexes and extends, and the magenta transverse axis in the femur about which the patella flexes and extends, and the longitudinal axis in the tibia about which it internally and externally rotates on the femur. And then let's do our resections, and we know because we measured these bone resections intraoperatively that all four of them are equal, so that the femoral and tibial components are placed such that the kinematic axes are aligned. Now let's look at a two-plane analysis to get an idea of what the three-dimensional malalignment is by mechanically aligning the joint line, and we'll show you that it changes the obliquity and raises the distal joint line from that of the kinematically aligned knee, but doesn't change the posterior joint line. So let's focus again on the mechanically aligned total knee arthroplasty. There's a projection again of the coronal and axial view of the femur, and there's the obliquity of the joint line, and that's the location of the femoral component. And that's the location of the transverse axis in the femur about which the tibia flexes and extends. And you can see that the bone resections off the femur are excessive and asymmetric compared to the posterior resections, which are less and symmetric. And this large resection on the medial side and small resection posteriorly on the medial side causes the knee to bind in flexion, and indeed that's what led to this patient's flexion loss. So there's a perfect example of how unequal distal and posterior resections will place the femoral component so the transverse axis and the femur are not parallel to that of the femoral component and not perpendicular to the tibial axis, and the knee is kinematically malaligned, leading to either stiffness, loss of motion, or instability if a thinner liner is placed in order to regain motion. So now you might have a little intuition as to which knee has the loss of flexion, and it's due to the coronal malalignment of the femoral component in the mechanically aligned knee. And if we look at this projection, you can see both the mechanically aligned knee, which is closest to us, is perfectly extends, just like the opposite knee, which is a kinematically aligned knee. And yet when we ask the patient to flex the knee, on the left, the mechanically aligned knee only bends to 45 degrees at 3 years, where the opposite knee actually flexes to about 105 at 4 weeks. So the cause of loss of flexion is the abnormal obliquity and raised distal joint line on the mechanically aligned side, which can be caused by referencing the femoral head and the variability in the shape of the femur between our subjects. So the message is you should probably strive to not change the obliquity or the level of the distal and posterior joint lines from normal because of leading to ligament imbalances that are uncorrectable with soft tissue release. And there's penalties. If you put a thicker liner in to create stability, you run the risk of stiffness in some position of the motion arc. On the other hand, if you're losing motion, you put a little thin liner in, even with your release, you can lead to this instability either in mid-flexion or deep flexion. You can get the unexplained pain where the patient has a good-looking radiograph but isn't happy with the knee, and the patient with chronic effusions that are unexplained as well.